The recent USAid funding freeze has sent shockwaves through our public healthcare systems, threatening things like our HIV and TB treatment programs, maternity health services, and many more. We're joined by Khanyisa Mapipa, an activist attorney as well as the head of the Health Rights Program at Section 27. With a strong legal background and years of experience, she has dedicated her career to looking at issues such as sexual and reproductive health, oncology services, and migrant health. Firstly, thank you so much for joining us today, Khanyisa. So I'm just going to jump right straight into it and ask, what does Section 27 identify as the core challenges in providing accessible healthcare to underserved communities in our country?
Section 27 is a public interest law centre that specialises in the right to access healthcare. We've been doing this work for over 30 years now. Started off as the AIDS Law Project with the initial case on Nivaropin, where our client was the Treatment Action Campaign. Many of your viewers might be familiar with that case. And so with that experience in mind, we have been through quite a lot of negotiations with government and talks with government. And some of the issues that have come up, or the major issue that's come up, is the availability of resources. So you might be familiar with the section in the Constitution that our organization is named after, specifically says that everyone has the right to access to healthcare and reproductive rights, but that has a proviso. There is a limitation on that, and the limitation is available resources. And so our government struggles quite a bit to make those resources available, and even when they are available, to make sure that they are used in the correct manner to ensure access to the service.
How would you say, from your observation, have you seen how these facilities have adapted to service the increasing demand of the need of healthcare, considering these resources or lack thereof?
It's quite difficult. It's rather difficult for facilities to adapt. Many of them have to work with limited staff, limited critical staff. So we're talking about availability of nursing staff, we're talking about availability of specialized doctors in some fields, and we're talking about availability of medication. So we as an organization, together with our partner organizations, would track some of this information. And what we found over the years is that the access to these services, as well as the access to this medication, is dwindling. And we've made this information available to the government so that they can make decisions based on the information that's available.
So we have your government-funded facilities, we have your non-profit facilities. So a lot of our viewers might not know what's the difference between a public clinic and a non-profit that might be offering those services.
The difference in operations might be minimal. So a public facility versus a privately funded facility or a foreign funded facility will typically operate in the same way. The difference becomes the funding of those facilities. So for example, with PEPFAR funded facilities, you often find those in districts or areas in our country where the need for those services is quite dense. So where the population perhaps requires added access to HIV treatment or added access to TB treatment. And so you would ordinarily find that those facilities are more populated in areas where the need is more. But with public health facilities, obviously you find them all over the country. The accessibility in terms of resources varies depending on the government of that province and the access to resources that the government provides for those facilities. For example, we all know the Western Cape province is doing much better in terms of healthcare than the Eastern Cape, for example. The Western Cape has predominantly urban area, is predominantly an urban area. The Eastern Cape, on the other spectrum, is more of a rural province with vast distances between where the people are and where public health facilities could possibly be, for example. There is a more concerted effort, particularly in the Western Cape, with things like sexual reproductive health. We know that in the Western Cape they've partnered with your Mary Stopes, for example, to try and take away some of the burden and the pressure on the public health system, and channel those patients towards the private health system to be able to do that work. In the Gauteng Department of Health, we as Section 27 just litigated a case now on radiation oncology care, where the government was given by the provincial treasury 784 million rand,
Wow.
specifically for radiation oncology treatment, and specifically to address the backlog of 3,000 patients who had been waiting for these services for about 18 months to 3 years. And they asked the Department of Health to outsource these services to the private sector, and our provincial department has failed to do that. So you can just see the differences in approach and the differences in understanding what is possible, understanding what is necessary in the circumstance, and making sure that the service gets to the people.
A lot of us have a misconception about, right? And that's the issue of foreign nationals' access to healthcare.
There is a section that says that requires the government to put in legislative measures to ensure the access to that right. So what those measures have looked like is government policies, legislation around access to the right. Specifically for migrant communities, we know that the policies are to include refugees and asylum seekers who are documented in the country to access those rights, but that's not always the reality, and that's not always what we see in public healthcare facilities. We see migrants being rejected from those facilities on the basis of xenophobia, or being asked to pay exorbitant amounts in order to access these very basic services. We've had to litigate in order to make sure that these rights are realized. A case in point is our maternal and health case that we brought in 2023 that relates specifically to access to healthcare for migrant mothers and children under the age of 6. Now, our National Health Act is quite clear on what the rights are for all women and all children living in South Africa. And our Act says that all women who are pregnant and lactating and children under the age of 6 are entitled to free services. But what we were seeing in Section 27 is scores of women coming to us to assist them to be able to find a safe place to give birth. Some of them ended up having to give birth on the side of the road, some of them having to give birth on the doorsteps of the hospital, hoping that someone would assist them, and each of them being turned away because of their nationality. And so we brought this case off the back of a very serious case that came to us, that was of Mrs. Ncube and her son, who passed away at the doorstep of the hospital because he was refused access to these basic services. Baby Ncube was a 2-year-old who had ingested rat poison at his house, and he became very ill, and his mother then rushed him to the hospital, and when she arrived there was still time to assist him, but they told her she needs to go back to her home to get his documentation, and that they couldn't assist him without verification of his documentation. Now, we know what the law says. Section 27(3) of the Constitution is quite clear. In an emergency situation, your nationality doesn't matter, your whether or not you have money doesn't matter. You could go to a private hospital in an emergency situation and they're constitutionally bound to assist you. But in this case, because of his documentation and because of his nationality, he was refused access. So the mother rushed back to her house, and on her way back to the hospital, the baby died.
Sure.
And so these are the kind of cases that we started to get at Section 27, and so we had to do something about it, and we brought this case to the courts. The court confirmed that the rights under the NHA, which is our National Health Act, which say that all mothers and all children under the age of 6 are entitled to access to health care. So all pregnant women and all lactating women and all children under the age of 6 are entitled to access to health care, free health care. It confirmed that right, and then struck down the policy that was enacted by our Provincial Department of Health or Gauteng Department of Health as unconstitutional and in conflict with the current legislation, and then demanded, which was more important, demanded that the Department of Health in the province advertise those rights. So not only that it needs to get rid of its policy, but that it needs to correct what it had done wrong, which is create this impression that these people were not entitled to their care. And so through that, we've been able to make some inroads in terms of access to migrant health.
All right. So as you're speaking, I actually do realize that this issue of documentation is not one that just affects foreign nationals, for example, right? So as a South African citizen, you could actually also come across the same issue where you are in an emergency, and because you don't have documentation to confirm that you are a South African citizen, you could find yourself in the unfortunate position as baby Mube and the mother. And it's really sad that such issues are still currently happening. What is the impact of such a big international cut on healthcare facilities in our country?
It is quite a big blow, and unfortunately our government has tried their level best to minimize it and to try and get people to think that it's a small issue when it's not. The current phrase that they're running is it's only 17% of what we budget for access to HIV treatment and TB treatment, and it's actually misleading, because they're not talking about what that impact of that 17% is, what it actually means. And in reality, what it means is that the health system is now a health system that was already constrained, a health system that was already being held together, is now 24,000 health workers less, has now 24,000 health workers less. And that's both permanent staff and part-time staff. What it means is that half of the counsellors that our HIV system requires or was relying on are now unemployed. And I'm sure you and your audience will be familiar with the role of a counsellor in an HIV situation. They do the testing, they give the counselling, they make sure that people who are on ARVs stay on their ARVs. So if a patient is not coming to collect their ARVs, they follow up, make sure people are on treatment. Those are the services that are now not there. Half of those people are now not employed. So to say it's 17% is truly misleading, because you're not saying exactly what that 17% represents. The other portion of those people are data capturers, who are also quite significant to our fight against HIV, because they record what the stats are. They record how many people are on ARVs, how many people know their status, how many people have a viral suppression or are virally suppressed. They record what our efforts towards HIV actually are looking like, right? And half of those people are now gone, right? So to say it's just 17% is completely misleading. You're not actually saying what the impact of this is going to be. And the impact is that people are going to die, because people are not going to take their ARVs, and nobody's going to follow up to make sure that they're taking their ARVs. People are not going to want to go get tested, because there's nobody there to test them or counsel them. Though that is what we are missing. And a lot of the other narrative has been, oh, these we've got enough money for ARVs, the medication is there. But we also forget what these facilities, these PEPFAR-funded facilities, represent. And they represent safe havens for some of the most vulnerable in our society. They assist women and children who have been abused. They assist members of our society who feel discriminated against. So, for example, members of our society in the LGBTQIA+ community. They also assist members of our society who are part of our key populations, like sex workers, who would be discriminated against if they went to the normal clinics or the normal hospitals that we all know of. That's why these facilities popped up in the first place, because there was a need. And the need means that people without that need being met will either not go on their treatment, or will not know that they need treatment, or will die because they're not taking or continuing to take their treatment. And so that is what is going to be now the missing link. And it is absolutely crucial that government plugs that hole. Otherwise, we will likely see a regression in our HIV efforts that is perhaps even worse than what we saw in the late 1990s and in the early 2000s.
You know, Khanyisa, considering the financial struggles that we're experiencing right now in our healthcare sector, what do you think should be those immediate priorities for patient care? What should we be focusing on to ensure that at least we can somehow keep the rollout going so that patients can still get the access to the medication and the services that they need?
One of the things that we think is really important is for government to make sure that they have a plan around key populations. They're key populations for a reason, right? Because they're the people that are most susceptible to contracting the virus, and the population that's more susceptible to spreading the virus, right? So those that population needs to be protected. And right now, in our state where we are, we don't have the facilities that were afforded to us by PEPFAR and funding like USAid. Those people are now being forced to go back to the public health facilities that they avoided in the first place. The whole reason, like I said, why we needed those facilities is because people didn't feel safe going to our public health facilities. And government has been quite silent on that. It's as if they don't realize the need, and it's as if they don't realize the risks that occur when key populations are unable to access these critical health services. And so what we've requested, and we wrote a letter together with some of our partner organizations to the minister, is for him to circulate at least a circular to his clinics, his hospitals around the country, to ensure that, to make sure that health staff understand that discrimination of any kind will be met with serious consequences. Because we need to, it's not enough to say we have health facilities, we have enough medication. It's not enough. People need to feel safe in health facilities in order for them to approach them.
But what would you say is our responsibility as civil society, to hold our government accountable for all of these things? How are we going to fix this issue?
Yeah. I think one of the things that is important is to make sure that we are in the room when the decisions are being made. Because as much as the government might have the raw data in terms of how many people have now lost their jobs and how many people are on ARVs, they don't know what the additional impact of all of that is. And so it's up to us to be in the room and to make sure that they understand. The other day, the minister, Aaron Matsoledi, he mentioned that there would be a contract with Deloitte. We are not sure yet if the contract has been concluded and the work is being done, but he mentioned that that what Deloitte would be tasked to do is to analyze and ensure that government is aware of what the gaps are that are created by this funding withdrawal, right? And the only way that Deloitte can do that is if they are talking to civil society and as if they are talking to the people, because that is who knows the information. Organizations that work on the ground, organizations that have been part of PEPFAR funding programs, funded programs, organizations that know where the needs are in communities, because communities aren't a monolith. We're not all the same, right? One community, in terms of how it deals with HIV and the struggles that community faces, is going to look completely different to the next community. And we need to have those conversations. And it's a huge task. It's an absolutely huge task to do. And it definitely cannot be done by one singular firm that has been appointed by the government to look into it as though we are all just numbers. Because a reality of lived experiences and lived lives. And we need to speak to that, and we need to make sure that whatever government comes up with is responsive to our needs. And so what I would like to see is government reaching out to civil society, reaching out to the organizations that have been previously funded by USAid and PEPFAR, and trying to figure out solutions around the needs that these organizations have been filling, the needs that are present in our communities and persist and will lead to the loss of lives if not filled.
What lessons can we take from this experience, to look at our sustainability in healthcare with this country?
I'd say two things. So the first is to ensure that the increase in or the additional funding that is allocated towards healthcare is funding that is above inflation. So before this current budget cycle, which we just had now on the 12th of March, what we saw as civil society is a culture of austerity that is building in our funding framework, right? What we're seeing, particularly within access to healthcare, is that each year, whatever the increase is below inflation, right? So it's eroded by inflation. And what that means is that in real terms, we're experiencing a decrease in the resources that are being put towards healthcare, while the system continues to grow, while a lot of people continue to lose their jobs, become unemployed, and then rely on the public health system. So we're seeing the numbers of people relying on public health growing, but we're seeing the number of, or the percentage that is being allocated each year diminishing and diminishing. So the government is having to do like a lot more with a lot less.
Yeah.
And this is what I was talking about in terms of resources, right? So the first is austerity and figuring out a way to tackle austerity. This year we saw a 7+% increase in healthcare funding, which translated to about a 3% increase, real term increase, which is the first time we've seen that in years in terms of funding for healthcare. So that's the first thing. If we can continue down this trajectory of making sure that the resources match the demand, then I think we have a fighting chance. The second thing is the culture of underspending and sending money back to Treasury that we've seen develop in our health systems. Our provincial health system has insufficient number of doctors, and yet within this province we have doctors who are unemployed, right? But yet each year we send billions of money back to Treasury. How does that make sense? Just the other day, the health ombudsman released that report around Mr. Tom London's complaint, and they released that report, and they basically said that the Helen Joseph is 400 doctors short of what they actually need.
That's a shocking number.
A shocking number.
That's a shocking
and
number.
yet there are doctors who are unemployed in this province, who are seeking, who marched. They marched to the Department of Health to demand jobs. And yet we're sitting with hospitals who have less than, who are needing 400 doctors. And yet year after year, we send money back to Treasury. So things like that really do eat away at the reality of the health system that people get to experience in this country. What kind of health system can you expect when you don't have sufficient doctors, when you don't have sufficient equipment, when your equipment isn't serviced, when tender processes are rife with corruption? What kind of system can you expect?
Just gonna take a look into the future, right? And I'm gonna bring up the issue of the NHI, right? The National Health Insurance Bill that was recently passed, right? So what is Section 27's stance with regards to that?
We are in support of universal healthcare. The idea and the notion of universal healthcare is one that is supportive of access to healthcare and access to that right specifically. It is the idea that everybody gets access to healthcare equally in a way that doesn't advantage one and disadvantage the other. We know that in terms of how our GDP is divided equally between the private sector and the public sector, that there's a need for a consolidation of some sort, and there's a need for us to find equity, particularly where the public health sector is dealing with 85% of the population and the private sector only 15%, and yet they are working with the same amount of money. Right? So we know that those things need to change. The question is how, right? And the NHI bill, when it came out, we made submissions. We made a number of submissions right through the process. And some of the things that we've identified that if they could be changed or if they could be fixed would give us a fighting chance with NHI to create a universal healthcare system that is equitable and that does what it's actually meant to do. One of those things is the centralization of the governance structure. At this point in the Act, the governance structure is quite centralized in the minister. So you have the minister being able to appoint the CEO of the fund, being able to appoint the chairperson of the fund, being able to appoint the board members of the fund, being able to appoint advisory committees that advise the board. And so power is quite centralized in the minister. And we know from past experience with other funds that we've seen, the road accident fund as one, that if we don't have checks and balances, if we don't have the necessary checks and balances in place, things can go seriously wrong, seriously quick, right? And so what we're calling for and what we've called for right through this process is to put in place those checks and balances, not only to protect the fund and to protect the money that's at stake, but also to protect the people that will be in that space, right? To make sure that whatever allegations of corruption or whatever it is, they can say, well, there's all these checks and balances, and we've ticked all of these things, and we make sure that the money goes to the right place. The other thing has been this issue of documentation in the Act. Now, if you're looking at the Act as a lay person, and you perhaps subscribe to the notion that only South Africans should access healthcare in the country, you might think that this is a good thing. Many South Africans are without documentation. What does that mean for those South Africans who have been up until this point able to access healthcare services in their various communities? Those people will now be outside of the system. They will now be ineligible to access healthcare facilities. So this is not just a migrant problem. It is a problem that will affect the most vulnerable of us, because the people who don't have documentation and are citizens of the country are the most vulnerable. That's the very reason why they don't have documentation, because either they can't afford the 60 rand that you need at Home Affairs to get an ID, or they can't afford to take a taxi to Home Affairs, or whatever it is. But those are the most vulnerable of our people, and we haven't fixed those problems even. We haven't even fixed our Home Affairs problems, and yet we are hoping that we can employ a system that relies on Home Affairs being at its peak.
Sure.
So it's things like that that will endanger the success of a universal healthcare system like NHI. And then the last thing is the exclusion of migrant communities from accessing basic care, right? And basic care will include your TB treatment, will include your HIV treatment. And we know that, these are communicable diseases, and they're communicable for a reason, right? If I am HIV positive, my neighbor is HIV positive if I don't have treatment. My partner is HIV positive if I don't have treatment. If my partner, because they are of a different nationality, can't access PrEP, can't access PEP, can't access ARVs, I'm at risk. It places the whole community at risk.
It's a shame.
TB works the same way. if your child is seated next to another child who happens not to be from this country, but that child has TB, your child has TB.
Sure.
It's a non-discriminatory disease, but we want to treat it like it is. We want to treat it like it discriminates against people based on citizenship, and we know that it doesn't. So things like that, we've made points in the submissions that we've made to the minister to say it's nonsensical. It's just going to make us chase our own tails over and over again, trying to treat the same communicable diseases while we spread the same communicable diseases in our communities. It was designed in a way that primary health care is accessible to all for this very reason. So we need to keep those things going. So we've made submissions of that nature. We've made other submissions based on transparency in the Act and accountability and things like that. We've made submissions on how the process ought to be piloted before it can be rolled out, so that we can see where the hiccups and the problems are and fix those before it becomes a nationwide thing and a nationwide problem. So we've made submissions, and unfortunately not a lot of them have been taken up by the minister and have been taken up by the Department of Health. And while we might not have all the answers, certainly our experience as a civil society organization that cares for people on the ground, that tries to be the catalyst and the voice for people on the ground and sees these things firsthand, certainly our contributions should be taken into account. But we haven't seen that happen. And so we worry. We worry about what it's going to look like in the coming years and what it's going to mean for our health system. And we're mostly worried that what it's going to mean is that it's going to be a worse health system than what it is right now.
There's a lot of information that is not given to the people on the ground. There's a lot of knowledge that is not given to us and our viewers, because sitting here today, there's a lot that I just learned, a healthcare system that I'm obligated to get access to. I really do hope that all the information and knowledge that we got from Khanyisa was helpful and you were able to, let it infiltrate and feed into your minds. Do not forget to subscribe and click that post notification button. Thank you so much for joining us for our episode here today.